Good afternoon. It's a pleasure to have Dr. Kalra with me today. Just a brief introduction. It's difficult to limit his introduction to a few lines, but I'm going to give it a try. So, Dr. Mannudeep Kalra, he is an attending thoracic radiologist at the Mass General Hospital, Boston, and a professor of radiology at Harvard Medical School. He serves as the director of the MGH Webster Center for Quality and Safety and scientific director of MGB Clinical Data Science Office. He leads a team of researchers in advancing the field of radiology through innovative research and dedication to improving patient care. Thank you so much, Dr. Kalra, for being with us. So, since you've spent so much time in thoracic radiology and in AI, how do you think AI is being used or can be used to improve the quality and efficiency of reporting in thoracic radiology?
Yeah, well, thank you for having me, first of all. It's an honor. So, from the point of view of quality and safety, the AI has many applications here. So let's start from, let's say, efficiency first, right? So the first thing that comes into mind with all the various AI options that are now available is the ability to triage what is more urgent versus what is less urgent. The second application that we have seen some traction in this area is the ability to actually parse the radiology report or radiology exams in terms of those that are quote-unquote normal or without actionable findings versus those that have got something abnormal and needs to be prioritized for evaluation. The other idea is using the efficiency for even work list distribution or workload distribution across, let's say, a specialty chest radiologist versus general radiologist. So that's another area of interest. From the quality perspective, we are lacking a little bit in terms of having a credible X-ray based product for detection, right? In terms of being able to mark out some of the areas with abnormalities. We are seeing that some products are coming up, but there's still more need. From the CT point of view, of course, we've got, including at our own hospital, AI tools that can actually look at the CT and both detect the nodules, localize them to the lobe and the lung, as well as segment these nodules and provide with diameters or volume estimation and classify the attenuation of the nodules in terms of whether it's solid versus mixed versus ground glass, as well as assign a lung rat score, which decides what is to be done next. And I expect that those aspects of AI actually have direct implication to the quality of service we provide, as well as help in doing a more efficient interpretation once you get hang of how to use this efficiently.
That's really great to hear, Dr. Kalra, especially in some parts of the world where there is still not legitimate but fear about AI in the radiology space. But it's great to hear from you that it is only adding to the safety and efficiency and accuracy. So that's great. Well, moving on. There is more that AI can do, right? So in terms of care coordination, how do you see the AI tools helping in care coordination when it comes to thoracic imaging?
Yeah, so I think there are two aspects of this. One is in places where you have got, let's say, you mentioned the developing countries and parts of the world. We know from our own, partnership with various kind of stakeholders and hospitals across the developing world that in many places the chest x-rays don't get reported or don't get looked at by a trained radiologist. And only the capability to acquire images exists, but not the capability to report. And I think in those countries and those places, having at least a good AI tool, I know that in several countries, there are some players, including Qure, which have a product to go through the chest x-rays and look at cases like, triage them for presence of findings suggestive of tuberculosis. That's a great one. In the Western context, like in my hospital case, setting, we have had some experience using AI tool, which actually find critical findings and then triage them for notification to the physicians directly. right? So these are the two separate pathways by which I think radiology and AI in particular can directly interface and influence care. And of course, the third element is to look at the quantitative aspects of imaging, where I think AI has a big role in terms of being able to provide volumetric estimation, in terms of being able to provide more reliable and robust and reproducible measurements, for example, with tools such as those that look at right and left heart strain, right? So there are several applications of AI where I see the AI directly influencing the care pathway, whether it comes to priority interpretation or whether it comes to priority communication with the physicians.
Understood. No, it's great, and you're absolutely right that it's not just the imaging AI or the reporting AI, but the integration with the workflows is very important, and the idea behind using AI is just so that it is seamless and it does not increase anybody's effort, right? So, great to know. You touched upon the role that AI plays in the underserved countries. So, would you like to talk a little bit more about how AI is able to improve access for thoracic imaging in rural areas or underserved areas?
Yeah, I think this is one of the area where there is very active interest in terms of various organizations which do a lot of humanitarian work across the developing or underserved areas. An example that I gave you was basically in pulmonary tuberculosis, where I am aware that, your company Qure, for example, has TB screening programs where you have shown, based on the presentations that you have made, that, it can have an impact where the radiologists don't exist, in terms of having, not just the detection of the finding in the X-rays, but also to the level of communicating the AI detected findings to the physicians and providing them with a dashboard where they can track the patient's compliance to the treatment and all that. So I think applications such as this, it's hard to train radiologists where there is no proper medical school or, let's say a tertiary care center. And I think in this domain, AI actually does help. In terms of getting access. Even in the developing, let's say beyond the developing countries, in the developed countries as well, we do see that the distribution of healthcare expertise, whether that be, let's say, CT or X-rays, is not homogeneous. So even in the most developed countries, there are parts where there may not be at the campus, radiologists available, and I think there it certainly does have a role.
Yeah, no, that's fair. That's fair, and I think that's the real application of AI, where there is no access, and it's great that AI can sort of help out in whatever way that it is able to. It's great. I also believe that AI is changing and progressing at a very rapid pace. So, and you must have also seen it developing over the last few years. So how do you see it, progressing in the next 5 to 10 years, specifically for thoracic radiology?
Yes. So, I think very good question, by the way. We have a lot of AI algorithms, and we have quite a few AI approvals in the terms of individual findings and some with clumped findings. Beyond a chest CT for, let's say, lung cancer screening or lung nodule domain, one of the issue that I think the next 5 to 10 years should solve is the transition from a triage or, let's say, work list prioritization to more detection tasks. So that's one of the things that I would like to see, and I think I can see that in the next 5 years. 10 years is a long time, that these tools for X-rays and CTs beyond just lung nodule, moving to the task of being able to detect, localize, and actually being able to either show heat maps or annotation maps of where the things exist. The second application would be that transitioning from, let's say, a single finding display at one time to multiple findings, across the regions, like say from lungs to the mediastinum, to the pleura, to the bones, right? So this multiple finding, this thing. And the third thing that I would like to see, perhaps not in 5 years, but maybe down the line at some point, would be this whole idea of autonomy, right? In the way that for certain findings that are more, let's say, quantitative. For example, in chest CT, if we talk about quantification, some of the things like emphysema detection and quantification, the measurements of airways, whether there is thickening or not, the measurements, for example, for coronary calcification, evaluation of bone density, evaluation of vertebral compression fractures. So some of those findings are very ripe for autonomous reporting. And it's not that the autonomous use of AI in chest would be the unique and the first example. We do have examples in the pathology sphere where there are, and in ophthalmology, where there are autonomous AI tools that are available to interpret, for example, retinal scan or to evaluate pap smears in patients suspected of, undergoing a screening exam for cervical cancer. So I think that's where I see the next, let's say, 5 to 10 years, or maybe sooner. We do not know. So I think that's where I would like the AI to go in terms of, being able to detect and mark and locate multiple findings beyond just a single finding at a time. And second, being able to achieve some level of autonomy for some of the quantified findings.
Oh, thank you. That was very, very enlightening, Dr. Kalra. And I'm specifically very intrigued by the autonomous reporting. And you already mentioned that there are precedents in diabetic retinopathy or pap smear. But when it comes to radiology or even plain films, right? Do you really see it happening? And you think it will help? It will help radiologists. It will help overall patients also.
So there are two reasons to think about. One is that chest X-rays contribute to about 40% of the imaging volume, and worldwide we do about 1 billion imaging exams. This was a data that's at least 5 years old, so we may have gotten well beyond 1 billion, right? And the time that we are spending reviewing images is getting shorter and shorter. The reimbursement for some of these exams are falling. So I think there is a real need to avoid radiologists' burnout. So I do expect that the AI will begin to pick up a bigger and bigger role when it comes to evaluating some of these X-rays. Some of the findings now will be more amenable to autonomous reporting. I am also encouraged with the developments that we have seen, for example, in generative AI or with this large language model, where there is an opportunity to enhance the radiological interpretation of the AI, whether that be in a chest X-ray or other modalities, using actual clinical data or using actual lab data. An example would be that you can pick up an opacity right now, but in a vacuum, you may not be able to decipher whether that's atelectasis, whether that's scarring, whether that's a pneumonia. But imagine having access to electronic medical records or the lab values and knowing the history of new fever, knowing the history whether this patient has got elevated, let's say, total counts or differential counts, right? And then coming to a conclusion that this opacity is likely a pneumonia. Okay, and that's where I think some of the roles of AI would evolve into.
Brilliant. Well, I think that's the future all of us do hope for. And I will just come to my last question, Dr. Kalra, which is more about the impact of AI on patients, right? So when we talk about AI, we definitely talk about making radiologists more efficient and faster and taking care of their administrative workload. But from your practice, and because you are so deeply integrated into AI in radiology, could you share an example of where AI actually benefited patient outcomes in thoracic radiology?
Yeah, so I think there are a few examples here that I can actually share with you. One is this, post-pandemic, we have had kind of a radiology workforce shortage and need, right? So we are seeing often some of the imaging tests are basically sitting around not reported for maybe a week or even longer. And some of these examples have had critical findings like pulmonary embolism and all that. And, I think being able to pick up such critical findings with certain triage tools and being able to report these, let's say within a day or within an hour of getting, notified, is a big advantage rather than having a 1 week turnaround. So we've had several cases where we've had undue long waiting time before we could actually finish up reporting. So that's one of the examples with work list prioritization where we have seen it make a real difference. The second is that we are seeing that because now it's the era of information access, the patients can actually see not only their radiology report, but their images, but also they can now see the AI outputs for some of these models that we have. Okay, so we are seeing sometimes the patients getting curious. Well, my AI, output showed a nodule there. You reported a nodule at some other place. What was the reason? It's just a small example, but it shows that the patients can be engaged, can be included. And the other big thing that I think I haven't seen from many people, but could be potentially, is this whole notion of using generative, AI to communicate directly with the patients.
Interesting. That's very interesting. Great. So that's all I had, Dr. Kalra. This was very, very enlightening, and it was great to gain so much knowledge from your experience. Thank you so much for your time today.
Absolutely. It's a pleasure talking to you. Thank you.